Hi everybody, my name is Dr. John Schnorr and I'm one of the reproductive endocrinologists here in Charleston, South Carolina. I work at a place called Coastal Fertility Specialist and have the pleasure of being the founder of Follicle Clarity. I've been a reproductive endocrinologist now for about 25 years. I trained as a fellow at a place called the Jones Institute for Reproductive Medicine, which had one of the first gonadotropin-stimulated pregnancies in the world. And during my 25 years as a reproductive endocrinologist, I, like you, have done everything I can to maximize the pregnancy rate of my patients. We work with very precise physicians and embryologists and clinical coordinators to do things as accurately and precisely as we can, with incubators that have precise temperature measurements and humidity measurements and have very specific media that we use and instruments that we use. And I often think a lot about what do we do in our field that could be better? What is the least accurate, most imprecise thing we do? And my personal belief is that's how we measure follicles and how we determine when a patient is ready to ovulate out and undergo the egg retrieval or not. If you look at the medical literature is very confused on this subject. There are many studies on the optimum follicular size, and the studies do not agree on what the optimum follicular size is. And one of the reasons for that, in my belief, is that we're measuring a follicle, which is a pocket of fluid, a cyst in the ovary that's got a very irregular shape, with two-dimension ultrasound, but it's a three-dimensional structure. And more importantly, we actually have multiple of these follicles that we're measuring in the ovary. So a patient may easily have, as you know, 10 or 20 follicles in each ovary, and it's hard as the clinician to measure each of those follicles and make sure you're not missing follicles or counting it twice. We have physicians doing measurements. We have board-certified ultrasonographers doing measurements. We have registered nurses doing measurements. We have medical assistants doing measurements. We have clinical assistants doing measurements who all have different degrees of training. Some of the people doing measurements do one-dimension measurements, just measuring the diameter. Others do two-dimension measurements doing the diameter. Sometimes those two dimensions are perpendicular to each other. Sometimes they're the maximum length on two occasions. Some people do three measurements. There's no standardization across the industry and in most of our practices. We have a relatively small practice here, doing about 500 IVF cycles a year. And with that, we have 12 different ultrasonographers who work in 5 different centers. They all have different degrees of training. They all measure in slightly different ways, despite our best efforts to standardize that. And I think that adds a lot of complexity to what we do. To help interpret when a patient's going to be ready to ovulate and undergo her egg retrieval, we use follicular size, we use estradiol levels, and we often use progesterone levels. And I would argue that estradiol and progesterone levels have become less important for us over time because we're using things such as germinase antagonist, which significantly suppress an estradiol level. The machines tend to vary in what their standards are. We're measuring things that are way outside the physiologic range, where normal physiology is an estrogen level of 200, and we're all measuring estrogen levels of 6,000 and 7,000 at times. And so all that makes it so that estrogen and progesterone is not as helpful as it used to be. And I would advocate that we need to go back and better understand the follicular number, the follicular sizes, and their growth patterns. And so it dawned on me one day when I was reading an article about artificial intelligence, that artificial intelligence can look at an image and determine if that's a cat or a dog in the image. The question that I had is, can artificial intelligence see a follicle? Can it measure a follicle, and can it track one follicle across multiple images? And so with that, I founded Follicle Clarity, where we now have developed that technology. And now through regular ultrasounds, we can use artificial intelligence to analyze the ultrasound results to improve the quality of care that your patient receives. And so what we're going to talk about through the subsequent videos is ways that which we can help you provide better care to your patients by, number one, standardizing how we do measurements, number two, doing the measurements much faster than they've been done, and number three, using your embryology data to reach in and understand what's optimum for your lab. What's optimum for your lab may not be optimum for our lab in Charleston or other labs across the United States. So that way we can individualize patient care not only for the patient but for the lab. Now, the challenge with what we do is that we don't have any new imaging technologies. It's the same ultrasound that we're all using, meaning if you're doing an ultrasound assessment and the ovary is behind the uterus and difficult to visualize, if you can't see it, artificial intelligence can't see it. But if you can adjust your machine to get an optimum view of an ovary so that you can see the follicles clearly, artificial intelligence will be able to see those follicles, it'll be able to measure those follicles, it'll be able to interpret the clinical outcome for those patients. The key is getting a good quality image. And in some of the subsequent videos that we have, you're going to be able to learn how to get the optimum image that you need. The system and software is set up so that instead of taking 20 minutes to go through an ovary with 30 or 40 follicles in it and measuring each of those, that normally takes a clinician 20 minutes to do that the right way. It literally is 10 seconds of imaging of the right ovary and 10 seconds of imaging of the left ovary. After 20 seconds, you're done with that patient. The images will show up on your computer and straight into your electronic medical record if your electronic medical record system allows for that. That then gives you time to review those images. It gives the physician and the rest of the clinical team a time to go back at any time and look at those images. Even though the patient's back at work, you can actually go through those images and see what the ultrasonographer saw, what artificial intelligence saw. If you find artificial intelligence was inaccurate, you can delete follicles that it overreads, you can add follicles that it underreads, and then with that, the artificial intelligence will help you determine when the best time is to trigger ovulation and to go ahead and do the egg retrieval. We are not perfect. Again, it's an ultrasound-based technology. If you can't see the ovary, we can't. If you're doing an ultrasound and you can't see the ovary well, you're going to be better at estimating where those follicles are than AI will be. But if you get a clear view of the ovary, AI can do that with 10 seconds on each ovary and give you a very clear output as to what your options are moving forward. Please keep us updated with how we're doing and do your best to maximize what the software can do for you. By entering when the egg retrieval is, you'll be able to help your laboratory team understand how many eggs they're going to get on Monday, how many eggs they're going to get on Tuesday, how many embryo biopsies they have to do 5 and 6 days down the road so that they can do optimum staffing. It'll also help your administrators with appropriate staffing. So I look forward to being on this journey with you. My hope is this revolutionized care within reproductive endocrinology. It's clearly the most inaccurate thing that we do, and this hopefully is going to be a nice technology to provide that accuracy. So I hope you're having a great day and look forward to meeting you one of these days. Bye-bye.